Bismillahirrahmanirrahim. I welcome all the participants on behalf of Pakistan Academy of Family Physicians. Before we start the proceeding, I'll request Dr. Idris Saab to please recite a few verses from Holy Quran. Jazakallah Idris Saab. As you know, our today's topic is joint cell arteritis. A very, very important condition because if not treated, it can have serious complications. We are lucky to have with us Dr. Haroon Saab, who is a renowned rheumatologist trained in Ireland, and now he is working at head of the department at Fatima Memorial Hospital, and also he is working at Doctors Hospital, Lahore. So I'll request Dr. Haroon Saab to please start the proceeding.
Assalamu alaikum everyone, and sincere apologies for the delay, for keeping you guys waiting. So the topic is joint cell arteritis. So as Dr. said, this is literally one of the dreaded complications that anybody can think of about this particular disease. In other words, why I was thinking it's important for the general practitioners and primary care physicians to really be aware of this disease, because this is, without a shadow of doubt, the most common medical emergency, or rather rheumatologic, not the medical, the rheumatologic emergency that you guys are going to come across with. Of course, rheumatoid arthritis, SLE, for example, so of course they're important, but it's not like that emergency if you like, compared to when you're talking about this particular condition, where of course the patient is going to present just with a headache. So we used to do, I remember when I was in Ireland, so we used to do dedicated joint cell arteritis clinic, dedicated clinics where we used to see these patients. And we also used to run what we call fast access GCA services. So we used to have the ophthalmologist, big ophthalmology university hospital right beside us. So when we used to get at least once or twice a week, at least patients coming and presenting with these complications, then we used to provide those services. So this is what it is. So I'm gonna talk a little bit. For the question and answer, are we going to delay it at the end, or are we just gonna keep going as we go? Because I would really like for all of you guys to just ask questions, and especially if there are any particular cases or case scenarios of the patients that you can think of, it's very important to just briefly discuss those ones as well. So joint cell arteritis is the most common vasculitis. So vasculitis, simple word, is inflammation of the vessel wall. So we know about all the different types of the vasculitis, but joint cell arteritis, without a shadow of doubt, is the most common vasculitis. And of course, it presents usually in the later age, or almost always in the later age, and it affects the medium-sized or rather large vessel vasculitis. It is classified as large vessel vasculitis, but medium vessels can also be affected, and it predominantly affects the aorta and the primary branches of the aorta. That's why mostly is the head and neck region which gets affected in this particular condition compared to other areas. For example, when you talk of the Wagner's and all this, there are other areas affected, for example, the kidneys and the ENT regions. But here you're talking about the primary branches of the aorta, the second and to third probably order branches of the aorta. It's always been considered. I remember a number of years ago we were discussing in a meeting, and there was one of the guys from Singapore, and he was saying, oh, we don't see this particular condition in Asia. And we were always like discussing why it could be. I remember there was a big topic at that time about the vitamin D, that probably in Asian countries the vitamin D is not that low, and the European countries the vitamin D is a lot low. So that could be one of the reasons why the people would have more of these vasculitis in the European countries. But I don't think that's right, because since I'm here, I even don't check vitamin Ds nowadays, because almost it's given that every person's vitamin D is low. And now I have seen at least more than a dozen of patients of the joint cell arteritis. So I personally do not think that it is low in Pakistan or Asian countries. I think it's low because we don't recognize it, we don't appreciate it. Because the patients are coming with a headache, and these are all patients mostly in their 70s. So who in Pakistan gets all these, the temporal artery biopsies and so many other investigations, comes with a headache and then gets, for example, the other complications. So that's why I personally think that we don't appreciate and diagnose these conditions. That's why it's quote unquote low prevalence. So if you look at the clinical features, for example, of the giant cell arteritis, so simply 75 to 90% of the patients are going to present with headache, or at least, have some features, or sometimes they're going to have a headache. It could be the initial manifestation, or at least it could be sometime in the later stage. They could be presenting with the fatigue, they could present with, for example, the temperature, pyrexia and all this. But at least 70 to 80% plus minus are going to have headache at some point in time in their disease course. So it's very important to appreciate at least this particular symptom. If you look at the other symptom, there's a polymyalgia rheumatica. It's not that common, but still 50 to 60% going to have polymyalgia rheumatica associated with the giant cell arteritis. And we're all very much aware of the polymyalgia, for example, having neck stiffness, shoulder stiffness in an older patient. So always think of, if any patient who is going to be complaining of some joint pains, and if they have some associated headache with this, we should always be cautious that it could be giant cell arteritis associated. So also fever is well there. So we'll talk about the fever a little bit later, but it's very important from this take-home message from this slide is that the headache is the most common symptom of this giant cell arteritis. And the headache is headache for us as well, because there is no particular characteristic of headache. If you ask me, for example, we know about the migraine, there's the characteristics, there's the other types of so there is no particular characteristic of headache. It could be of anything. So the most important thing about the headache is the new onset of headache. It's not like something, I have the headache for so long. And what I say is, who doesn't have a headache? We always have a headache. So it's not the headache we should be asking about the new onset of the headache. Most of the patients would recognize, okay, this type of the headache is different compared to what they would get it, for example, years earlier or something. So what happens in this particular condition? As I mentioned, this is
ये आपने उसके अंदर लिखा है कि jaw claudication is more specific. इस पर थोड़ा सा बता दें.
जी there's a slide on jaw claudication. So we'll deal with the jaw claudication. So as I mentioned, in vasculitis is the inflammation of the vessel wall. So this is a granulomatous, means there is a granuloma formation in this particular vasculitis. So all three layers of the vessel gets affected. We know the three layers, for example, the adventitia, media, and the intima. But most important is the intima and the media, the inner wall or the middle wall of the artery which gets affected, which gets involved in this particular condition. So what you're seeing, for example, in the second one, you don't see the cursor there. Is it pointer? Sorry. So what you're seeing in the second one, which I mentioned, is intimal hyperplasia. Means the vessel wall, when it gets swollen, when the middle wall is swollen. Thank you. So what you're seeing here is this is the intima and this is the media. So when it gets swollen, so what you're seeing is the lumen is getting smaller. Clear? So when it's much more swollen, so it's intimal occlusion. So then eventually what we're seeing is that the whole arterial wall or the lumen is blocked. Clear? And that's what's going to happen then eventually is when there is no, of course, the whole arterial supply of that particular organ is affected, particular tissue is affected, of course we're going to get ischemic symptoms, and that's what you are getting, for example, the blindness or the stroke. So this is the whole sort of what happens in this particular condition. There is a inflammation. When it gets, of course, it remains unchecked. There is a significant hyperplasia. When it gains, it remains unchecked. There is a complete blockage of the temporal artery or any other artery which gets affected, and then there are ischemic eventual complication of whatever organ or tissue is affected. So this is to date. So this was designed in 1990 about this diagnostic and classification criteria. If you look at it, it's very, very simple. But unfortunately to date, this is the gold standard that how we diagnose this condition. I mean, if you look at this, it's so simple. So age of onset is more than 50. right? New onset of the localized
In all
headache.
the cases, or it can
Almost always. Rather, not almost always. It has to be more than 50.
more than 50.
I'll mention that in this later. So it has to be more than 50. ESR is more than 50. The new onset of the localized headache and the temporal artery abnormalities. So some person comes, of course there's a temporal artery pain there. So we need to palpate those arteries. So usually what happens is when there is an inflammation which remains unchecked, which remains there for some period of time, the arteries gets thick. It gets a little fibrotic. So it's easier to palpate. You can easily see it. If you feel the temporal arteries and you see that it is nodular and thickened, so you can be almost 100% confirmed that that's what you're talking about, that this person has got giant cell arteritis. So the temporal artery abnormalities. And then the lastly is the temporal artery biopsy finding. I won't go in that detail, but those are typical vasculitic sort of the finding. But the most important thing is to look at the box there. So if 3 out of those 5 are present there, the sensitivity and specificity is more than 90%. Means that you don't have to have the biopsy to get the confirmation. Of course, it's ideal. We should always be trying to get the biopsy. But I'm just trying to say that the 3 out of 5 means age of onset more than 50, there's a new onset of the headache, and the ESR is more than 50. I mean, you can imagine it's very, very simple. It takes how long? Very, very quick to make. At least it's suspicious. I have to have a very high suspicious of giant cell arteritis. You can reach there. But the problem also at the same time is the major problem.
Excuse me, sir. Yes, इसमें कोई CRP का भी कोई रोल हो सकता है?
Yes, CRP they didn't include in this one, but definitely has to be. So
raise तो होगी.
Oh, definitely.
Criteria में अगर include नहीं किया, that's something different.
Exactly. So has to be the both. So what I personally do is the CRP, not ESR, because in ESR.
That's why I asked the question.
Because
वो
they,
ज़्यादा sensitive है. CRP
वो ज़्यादा sensitive test है.
Exactly, because this was 1990 when this particular diagnostic criteria was devised.
पुराने हैं.
But
So-
they are, even now they are writing ESR.
ESR,
CRP is not written even now.
CRP, unfortunately, because of course in local settings we need to be much more careful, because of course when I came, so I always requesting CRP. CRP costs 2200, 2300.
महंगा टेस्ट है.
ESR costs about 150, 200 or something. So that's why in local settings we have to be a little bit mindful
ठीक
of
है.
these simple things.
That's right.
But again, in the older age, of course, we need to be careful. Again, with age, of course, we know that the ESR also goes up. So that's why that particular number is very important. Of course, no matter person is 150, the ESR shouldn't go more than 50 just purely because of the age. So it means some inflammation is going on. So one thing I made the point is it would be very easy to get to some sort of having a clinical suspicions of GCA. But that comes with a major problem, and that is you're talking about the elderly patient.
अच्छा, again मैं छोटा सा
And-
वो जो 3 आपके criteria, let's say the patient falls into 3, we should act immediately.
Absolutely. That's what I'm saying. We'll talk about that. That's absolutely. So we'll talk about when we're discussing the management thing. So as I mentioned, that the symptoms and the signs are of course very non-specific. Of course, who doesn't have the headache? Who doesn't have the pains and aches nowadays? So that's why, and you're talking about the elderly patients. So that is a major diagnostic problem at the same time. Okay, because we are of course concerned about the consequences, that we do not want to miss the giant cell arteritis, because of course we know that the ischemic complication, of course the blindness is very, very common in these if we miss it, and also of course the stroke as well. But at the same time we need to be extremely careful not to overdiagnose, because on one end, and I just want to make a case that it's a soft symptoms, we should not delay, but at the same time we should also be careful not to overdiagnose. Why? Because you're an elderly patient, and the treatment of course is the high dose of steroids. Of course, so that's why it's a little bit of diagnostic dilemma. Rather than jumping on to like, okay, this is what it is, we should also be a little bit worrying regarding the consequences. So
That's the consequences of steroid toxicity.
G.
Means, what do you mean by
Steroid toxicity, because we are talking about the elderly patients. These are the patients who I'm going to mention that later on as well, because most of these patients are going to have vertebral fractures, osteoporotic fractures. They're going to be diabetics.
But this is the treatment. Mainly this is the treatment. Steroid is a treatment.
Steroid is a treatment of choice.
Or
But what I'm
Most
saying is
people
on one
feel like
end, what I wanted to say is on one end, of course, we do not want to miss it because the dreaded complication of the stroke and the blindness. And the other hand, of course, we also need to be mindful of the steroid-induced toxicities. So we should be playing the middle ground at the same time. Or at least if we do expose somebody to steroids, we should have a clear plan that, okay, how long or how big doses we should be exposing that person to, or reaching to a firm diagnosis sooner than later, rather than just on the suspicious of GCA, putting somebody on high dose and remaining on some dose for a long period of time. That's the only thing that I just want to highlight.
Yeah, let's say we as in general practice, let's say I'm sitting in one of the remote areas, there I simply suspect this, but steroid is not going to do anything within 3 days.
Steroid is going to work straight away.
In 3 days, it is not going to do any harm. In 3
Harm,
days.
exactly, in harm, absolutely.
Yes,
शॉर्ट कोर्स तो दिया जा सकता है.
That's why I just mentioned that again we need to be having some plan in action. That okay, if I'm sitting here, I need to either consult a specialist or somebody. Okay, I'm weak at 10 days. I should need to get to some diagnosis. Is the diagnosis confirmed or not?
Okay.
Right? If the diagnosis is not confirmed, then of course we need to withdraw the therapy earlier than later.
Okay.
So in the short run, of course, we should have the question of steroids, right? We'll mention about what doses and what we should be talking. So just for simplicity, and of course very important for us as well, that we generally define or subclassify the symptoms into 3. One is the cranial symptoms, and the other one is the cranial ischemic symptoms, and then of course is the extracranial symptoms. So this is just the broad sort of subclassification, if you like. Cranial is the symptom, means like headache there, jaw claudication there, neck pain there, PMR for example, and so on. And the cranial ischemic symptoms, of course, these are the 2 main ones that we should not forget at least. One is the blindness, and of course is the stroke. And then the extracranial symptoms as well. For example, of course, this vasculitis we are talking about, so there could be other vasculitic symptoms somewhere else. For example, the distal aorta could be affected and so on. So these are the extracranial what we talk about. So the initial workup. The most important initial workup is, of course, having the good history and all, apart from the getting the labs. In the labs, of course, the important thing is the inflammatory markers. So simple thing, of course, what we should do, I've wrote a little bit more there, but that's more looking at what could be the other sort of the differentials, if you like, of these headache. So the ESR and CRP is the most important. Try to get both if somebody can afford. Because I've seen a lot of times either ESR is normal or the CRP is near normal, but the other test is grossly abnormal. So it gives you a little bit of better clue that something is happening. And again, we need to get some workup as regards the creatinine and so on. So important one is the inflammatory markers. And then the temporal artery biopsy. We should always be trying to get the temporal artery biopsy. Internationally, we are relying a lot on other, for example, the temporal artery ultrasound. So internationally, there's a lot of emphasis that we should forget about the biopsy and all this, rely on the ultrasound. But I can guarantee you, I don't think there's anybody in Pakistan at least who can be, for example, we can reliably trust purely, because this is a very sort of specialized, these are not the simple ultrasound that we deal with. We are talking about an artery's ultrasound, and there is a halo sign there of the inflammation. So in simple words, we should always be trying to get the biopsy done from the vascular surgeons rather than the general surgeons, because we need a little bit of the bigger artery size.
Chest X-ray का क्या role?
Chest X-ray we do deal, we'll tell a little bit later on. It's just because we are talking about the thoracic aortic aneurysm. It's a very common in these patients. So when we are going to follow up these patients, so every year, every at least 2 years, because these patients can have what we call asymptomatic disease. So they could be having ESRs are normal, headache is gone, but there could be a little bit of ongoing inflammation going on. So which is very, very common in these patients, which I'll mention a little bit later on in the last slides. So this is what we call the GCA Mimics. So if you look at, there are literally dozens of the mimics of giant cell arteritis. On one hand, as I'm saying, it's very easy to reach to a diagnosis, or at least to get a high suspicious of giant cell arteritis. But if you look at these differentials, the mimics, there are literally so many of them. Look at the pain syndromes, the migraines, and the TMJ problems, the sinusitis, for example, the localized so many. So there are dozens of those ones. right? And that's, of course, is always going to give us a little bit of put us on our toes when we're going to talk about dealing with the giant cell arteritis. So glucocorticoids regimes. So one is uncomplicated giant cell arteritis. So it's very important to just a little bit understand uncomplicated. Uncomplicated in simple word means when there are no cranial ischemic symptoms. Means if somebody is coming to me just with a headache but no eye symptoms. It means there are no end organ symptoms affected. This is just a headache or just a jaw claudication, for example, or other symptoms there. So these are uncomplicated. So in these patients, even low dose of steroids up to 40 or 30, that can be enough. So you don't have to go with the infusions or 1 milligram per kilogram or 60 milligram of steroids, the Bardone that we always use, right? So the one is, of course, the ischemic event that the people come and we always ask about the visual symptoms. And the visual symptoms are also, again, very difficult, just like headache. The visual symptoms, there are no particular characteristics of the visual symptoms. So it's not like they have to be having blurring or anything. So there could be even floaters, there could be anything. So the new onset of the visual symptoms, we always need to be concerned, and these patients should be started at least on 60 milligrams of delta corticoid straight away. And of course, looking at the PPIs and all this. How to reduce and how long these patients should be exposed to these steroids, that's unfortunately big. That all depends on, of course, the patient's response to treatment, right? If the patient is responding, generally this is the very sort of, if you want, 30,000 view of the GCA induced, the complication, then of course the steroids reduction regime, if you like. So that's the one we try to follow, but it's, if you ask me how many times I'm successful in following this particular prescription, probably 80% I fail to follow this prescription, because of course every patient behaves differently, because what we are following are the symptoms, very, very important. And then of course comes the ESR CRP. A lot of times people come with the normal ESR CRP, but the symptoms are there. I follow more symptoms than just the CRP and ESR. So it's very important. So that's why these all steroid business little bit goes up and down. That remains the case. And how long, for example, so usually most of the patients, you will be very, very lucky to see somebody whose steroids were reduced or finished off within 2 years. Mostly would require well more than 2 years. But again, that all depends on a lot of other things. So this is what we are talking about, 1.5 to 2 years, that would be, but mostly patient would require up to 5 years. And the cumulative dose, if you look at the steroids, for example, in these patients is 6.5 grams. And that's a lot of studies have shown this. And this again, up to 62% of the patients of the giant cell arteritis are going to have at least one relapse of symptoms. So you start on treatment, Zabardast is the treatment response, but the moment you start reducing down the steroid dose, at some stage there's going to be the relapse of symptoms. So 60% plus minus going to have some relapse. And again, the multiple side effects, for example, if you look at, there's a big list there of the potential complication of the steroids. And again, the last one is much more worrying for us at the same time. In the one big cohort of the giant cell arteritis, more than 86% of the patient had at least one adverse effect because of the steroids. More than 86%. Of course, because we're talking about 70 plus minus age bracket patient with high dose of steroids. Right. So I'm not going to spend much time, but I'm just going to highlight in this one that we have been trying, of course, the rheumatology word for so long, that what could be the alternative to steroids, or what could be the potential steroid sparing agent, in other words. So there has been some success with the Methotrexate, and there has been some studies done with a very sort of a modest response. So it wasn't that of success compared to what we see in other diseases. And the same has been with the azathioprine or the Imuron. It wasn't of much success. With the cyclophosphamide, there was some success, but unfortunately, as we all know, that the cyclophosphamide is a very, very potent immunosuppressive. Giving cyclophosphamide to even very elderly patients, of course, there's a much more adverse events, and that's why this is not sort of recommended anymore. Then we looked at the other biologics, the anti-TNF, for example. The take-home message is, unfortunately, there is no major response with anti-TNFs. However, the big breakthrough in the giant cell arteritis world came when there were all the biopsies tested, that there was one particular cytokine, IL-6, which was very much sort of overexposed, not in the biopsy specimens, but also in the blood or the sera of these patients. And this is, we know about the IL-6. The IL-6 inhibitors has been in use for rheumatoid arthritis for well more than a decade. The IL-6 inhibitors, the Actemra, Roactemra, which we use for rheumatoid arthritis, as I said, for a very, very long period of time. So this was the big breakthrough in the giant cell arteritis, this particular study which was published in New England Journal. So what it's showing here is that so if you look at, these are the four the slides there, the graphs there. So the first one, what you're seeing is that these are roughly around 80% of the patients who were started on this particular biologic, what I mentioned about IL-6 inhibitors, Actemra, Roactemra. So the 80% of the patients who were given this particular biologic over a more than 6 months period of time remained absolutely relapse free. So the 80% of the patient did not have any relapse, right? So this is the Tocilizumab once weekly, and then this was fortnightly of the same, and still there's around 80% or something that did not have relapse. And this is the patient who was given steroids with the 26-week taper, means the steroids were tapered within 26 weeks. They were still, what you're talking about, around 30% of the patient to 40% of the patient. So what simply from this is what you're seeing is that if you rely on steroids only, even though you give them steroids for a year, more than 40 to 50% of the patients are going to have relapses. Although we are giving steroids for more than a year. But if you give this particular biologic, which is once a fortnight biologic, very much in use for more than a decade, has been in very much use for this COVID business, right? It's very much effective for this particular regime, for this particular giant cell arteritis. And this particular study, when the patients were given this particular biologic and they were taken off steroids, right? They were given just the biologics and they were taken off steroids, more than 80% of the patients did not have any relapse of the giant cell arteritis. So this was a major breakthrough, and that is the only licensed treatment, this particular biologic, for giant cell arteritis to date. So again, this is just a very recent sort of the poster which they mentioned, they're looking at should we be given Methotrexate, for example, with this particular biologic or not, and the study didn't show any major improvement of adding any other biologic with any other DMARDs with this particular biologic. So let's quickly look at some of the myths and pearls. So this is, again, I was asked about the same, that the GCA ever occurs before the age of 50. So this particular, for whatever reason, is still we are not clear, whatever the basic philosophy or the physiology or pathology behind it, but it does not happen before the age of 50. There's a one big study from the Mayo Clinic of more than 1,400 biopsy-proven giant cell arteritis. When they looked at, there were only, I think, 2 patients who were aged less than 50 out of more than 1,400. It was retrospective. And of those 2 patients, which they found out their age was less than 50, they were very much clear that that did not have giant cell arteritis. That particular, the other 2 patients had some other form of systemic vasculitis, not the giant cell arteritis. So the age bracket is very, very robust in this particular condition. So other thing is, for example, the patient comes with a headache and we palpate the temporal arteries, and the temporal arteries are non-tendered or they're sort of normal on examination. Can we exclude the diagnosis? So clearly that is not the case. So the temporal arteries can be normal. Why? Because this is not temporal arteritis only, right? This is giant cell arteritis. I'll mention that later on as well. The temporal arteritis, because we do the biopsy just because this is the most convenient sort of the anatomic location of the artery to get the biopsies. That's why we call this, unfortunately, labeled as our temporal arteritis, but this is not. It could be occipital, it could be somewhere else, it could be inner side, right? So this is disease is not localized to temporal arteries. Be very clear. So that's why the temporal artery examination can be absolutely normal in this particular condition. So we cannot exclude.
इसको जो temporal arteritis भी कहते हैं, तो इसकी reason तो यही है कि most commonly temporal artery ही involve होती है. So
because
the second name is temporal arteritis.
So that's what I'm saying. We do not generally try not to call this temporal arteritis purely. I have seen patients with purely hospital artery fracture. I've seen one patient who had just above the eyebrow, that was the only infected area. That was it, nothing else. And I'm going to mention there, we have seen patient absolute strokes, but nothing affected at all.
इसमें सुपरफिशियल आर्टरीज इन्वॉल्व होते हैं, ये डीप जो इंट्राक्रेनियल है, जैसे टेम्पोरल सुपरफिशियल टेम्पोरल आर्टरी तो बाहर है और उसको इजीली पैल्पेट भी किया जा सकता है, फील किया जा सकता है.
I'm going to mention that in next slides about the extracranial and intracranial sort of. So I've just mentioned this, that we could be lucky that if we find those fibrotic or thickened arteries, because that would mean the chronicity of symptom. So if somebody comes to me with a symptom only of 4 days or 5 days, I should not expect that the arteries will be very thick, right? Because that would mean, as I said, that the symptoms, that would mean the chronicity of symptom. That would mean the arteries are more fibrotic. That's why I'm easily able to palpate them. So normal temporal arteries on examination we cannot exclude, right? So is the jaw claudication. Of course, the jaw claudication, we know that of course the patient would complain, but the very important to understand that it does not require a thick piece of steak to elicit jaw claudication. It doesn't mean that I have to have a big chunk of something thick to elicit jaw claudication. Jaw claudication comes very, very quickly, and even with a soft diet, and comes very quickly, as I said. It's not like after 5 minutes of eating it would come. It would come within first few seconds, and could be the soft food as well. And here if you look at, it's not that this particular TMJ area we should be worried about. I've seen patients just with the tongue gets tired, right? So the facial pressure while talking, reluctance to eat meat because of difficulty chewing. I've seen patients literally they're losing the weight. Why? Because they're reluctant to eat. They will not say that they are having jaw, but they say they always feel discomfort. They goes off food, for example. So those sort of very non-specific symptoms which can be because of that particular jaw claudication, if you like.
इसमें टेम्पोरल मैंडिबुलर जॉइंट नॉर्मल होता है बिल्कुल, या उसमें भी कोई इन्फ्लेमेशन के एलिमेंट होता है?
There should be no TMJ joint. There's no TMJ joint involved.
This is referred to.
Exactly. It's ischemic. Yeah. So this again is very, very important to take home message if you want from this slide. So any new unexplained pain above the neck in a patient who is more than 60 years and who has high inflammatory markers, always have the suspicion of CRP and ESR. I have seen this so many times. Just purely, I ask patients, they would come, for example, even in the family members I have seen. So just go slow, for example. For example, the older patient, they can do this because what they do is the older patient, they tend to modify their activity depending on what they can do or what they cannot do. So they're not going to tell about the joints, for example. It's not arthritis. It's not, for example, the rheumatoid or something. They're not going to complain of a lot of pain, but they're going to go slow and they're going to modify their daily activities accordingly. So any new unexplained pain with high inflammatory markers, always be suspicious about giant cell arteritis. So as I mentioned here, the headache and jaw claudication, of course, these are the typical and the most common symptoms, but they could be also, as written there, pain over the nose, in the ears, along the jaw, in the throat, in the mouth, and especially over the occiput as well. As I said, the occipital artery can be affected. So the pain could be in anywhere, as you mentioned rightly. So the temporal artery, of course, is the most common area. So the jaw area. So that's why it gets that big name. So then comes the paroxysm of unknown origin. So if you look at any patient who's more than 65 years of age, and the PEO, around 15 to 60% of the patients are attributable because of the giant cell arteritis. It's very common. I've seen this so many times that the patient is going to have the temperature features, and they of course get labeled to the sepsis and so on. GCA only affects the temporal artery, as we were just discussing. We just named this because of the convenience of the sampling. There's a wide range of other vessels affected, and as mentioned there, sometimes they can be absolute sparing of the temporal arteries in this condition. The visual loss, the most dreaded complication. So there are 5 known mechanisms. So what you're seeing here is the arthritic anterior ischemic optic neuropathy, which is the most common. The eye findings, the fundoscopy findings, which you're going to come across with, where there's the posterior ciliary arteries affected. Posterior ciliary arteries are right there. So they actually supply the critical neurovascular junction. So that's why this supply is there. This leads to what you're seeing here, that the disc is of course the edematous, it's pale, and there's also the cotton wool spots there as well, the ischemic symptoms. So this is the typical, more than 80% of the time, that what we tend to see in the patients who have blindness or the visual symptoms. The second one is what we call posterior ischemic optic neuropathy. So what means here is that the more proximal branches of the posterior ciliary arteries are affected, and what they actually supply is the more proximal part of the nerve. So that's why in the initial phase of what we call posterior ischemic optic neuropathy, the visual findings will not be there. So would be a patient coming, might be blind, but when you're going to do the fundoscopy in the initial phase can be normal up to 4 to 6 weeks. It will be later on that we'll be able to find the examination findings, the typical of suggestive of the same. Then there could be central or retinal artery branch affected. That could be another mechanism. Then there is a whole ophthalmic artery which is occluded, because of course there is the entire eye is ischemic, the orbit is edematous, and there is ophthalmoplegia. So this comes, I don't think I need to mention this here, but I think we are absolutely clear that the normal fundoscopy cannot exclude the diagnosis of GCA. As I mentioned here, firstly, that the temporal artery examination cannot exclude. The same way, the eye findings, the fundoscopic findings cannot exclude the diagnosis, or even somebody could be blind, but the ophthalmological examination can be normal in the initial settings. Right. So again, this is important thing to understand as well. So the unilateral pain. So any person comes to elderly patient who has the unilateral headache. So if you look at the odds, are there more odds that this patient has got giant cell arteritis, or there are more odds that there could be more what we call thromboembolic phenomena? So there are much more odds that this patient could have more thromboembolic phenomena rather than what we call the giant cell arteritis, because these are the patients. So that's why some things can be helpful in this. So that this patient has got, for example, the typical atherosclerotic, the typical precedings, for example, the diabetes, hypercholesterolemia, hypertension, and so on. So that's why unilateral headache in an elderly patient, we should not always be thinking just a giant cell arteritis. There could be thromboembolic, but rather is more common diagnosis. Should we be referring every patient who we are suspicious of giant cell arteritis to ophthalmologist? Perhaps not. But again, for every patient who does have eye symptoms, we should be referring them to ophthalmologist. So should we be starting patients on treatment of steroids before getting the biopsy done? So I think we're very clear, just purely for the sakeness. A lot of surgeons, they always mention, oh, don't send the patient unless they get the biopsy, or send the patients early. So very important, we should be absolutely not be hesitant in starting the treatment, starting the steroids very, very early. The biopsy can wait, of course, 2 days, 3 days, even a week, 2 weeks. Of course, it's not going to be that typical findings, but at least forget about the findings. The important thing is to save the eye, to save the complications. Clear? For example, if you look at one of the studies, which again from the Mayo Clinic, when they looked at was the biopsies, that how long these patients had the treatment before the biopsy taken, and they were able to elicit that within 2 weeks, if done, that there are classic features. But after 2 weeks, there are going to be what they call atypical features that might not be the true intimal hyperplasia, but the good pathologist can easily get a clue from those biopsy specimens. In other words, if somebody has been exposed to steroids, we should not be hesitant in sending that patient to get the biopsy done. We should try always to get the biopsy done. Again, we'll be discussing about the intracranial, extracranial part. So this is another one myth that people say the GCA does not affect the brain or does not affect the intracranial. It holds true to a lot of extent, because it, in typical sense, does not affect the intracranial. And there's a lot of different reasons why it is so. The people think that probably when the arteries enter the cranium, actually they lose their internal elastic lamina. So they lose that component of the internal of their arteries when they will enter the cranium. But again, there could be a lot of other things which can cause intracranial complications. For example, I'm going to share a case with you. So this is the patient who, in Ireland, we used to run what we call the stroke services, not us, the geriatricians. So every patient who would walk in, every patient who would have transient ischemic symptoms or the full-blown stroke, they would be looked after by the what they call the stroke team. So in their the performa, in their assessment plan, the ESR and CRP was included. So every patient walking in with a stroke or TIA symptoms or the vertigo, elderly patient, the ESR and CRP would be checked. And if that remains unexplained, we were called to get the opinion that could this be stroke associated with the giant cell arteritis. So this particular case is the same. So the 76-year-old, he had a month history, of course, the typical the stroke symptoms. This particular patient also had typical atherosclerotic risk factors, for example, the hypertension, hypercholesterolemia, smoking, coronary artery disease. So it was very easy to make some association that that's what the cause of the stroke is. But this patient did not have any headache or temporal artery palpation in the hindsight. But his ESR and CRP remained very high, and it was very much unexplained. So that's why, of course, the rheumatologists were called in to give their opinion about the giant cell arteritis. So again, because there was no clue where this is coming from, so we got the biopsy of the temporal artery. And we were absolutely amazed to look at the temporal artery, and that's what you're seeing here at the bottom one, that the whole temporal artery was blocked, was completely excluded of the inflammation. Right? Because, of course, because that patient was having the stroke, so he didn't, of course, was able to give the good history. He was not able to tell about the headaches and so on. But again, this is the CRP, and when we got his intracranial angiograms, we were able to see that the vertebral artery was affected in this particular condition. So vertebro-basilar insufficiency, this is one of the common in giant cell arteritis, has affected the vertebral artery that can give rise to the vertigo especially, and again the posterior circulation symptoms, the unsteadiness and so on, that could be one of the complications of the giant cell arteritis. Aortitis, so this was the question earlier asked about why do we do the chest x-ray in these patients. For example, if you look at the association of aortitis, remember I mentioned this is the inflammation of the primary branches of aorta. So if you look at the aortic aneurysms, for example, this is 17 times more common in this particular condition compared to of the same age population. 17 times more to have the thoracic artery aneurysm. So that is one of the reasons why we get the annual or at least 2 yearly chest x-ray done in these patients just to look for anything. And the abdominal aortic aneurysm are also 2.5 times more common. So it's less common, but it's still much more common compared to another person. So and every patient who used to come to our giant cell arteritis clinics, we used to get blood pressure checked in the both arms. This is another thing which we should also be trying to achieve, because again, there could be, as I mentioned, the primary branches of aorta, there could be subclavian artery, for example, the blockage or the aneurysms there. So that could give you another simple clue. That could be another extracranial, for example, the involvement or extension of this particular vasculitis. I think I'm done with my part. So the take-home message, if you want, is a simple, that any patient who comes with us above the age of 50, although by definition, but I would say more than 60, 65. Because if you look at the highest sort of the peak of these patients' age bracket is the 70, not 50. So that is around that particular, so it's a 65 plus minus, unexplained pain or discomfort or any weird feelings with associated high ESRs in CRP, we should always be concerned about this particular diagnosis. And again, it's very easy to make the diagnosis, but also at the same time, we should always be concerned about the potential complication of steroids. But also, if we have the good diagnosis made, we should be reassured that we have a very good alternative to steroids in the form of biologics, which is very freely available in Pakistan. Thank you.
Thank you very much. What is the prognosis?
So if you look at
Survival.
there has been very recent long-term studies done looking at the mortality. I don't have the reference to those ones. And the mortality studies were very reassuring that if we have the proper early diagnosis made, good treatment plan given, that the mortality, there was no change.
they say about 5 years or something.
Um,
Is that?
No, I don't have the particular figure, but as I said, the mortality rates were comparable to general population who does not have the disease. Who doesn't have the disease.
स्टीरॉइड की डोजिंग जो है ओडी डोज ही जरूरी है या इसको डिवाइडेड डोज में भी दे सकते हैं?
The preferable is once a day dose because in elderly
टैबलेट्स उसकी बड़ी ऐसी हो जाती है पेशेंट को सस्पिशन हो जाता है किसी भी अस्थमा में भी दें जैसे कहते हैं ओडी डोज दें अब 5 mg की टैबलेट है प्रेडिसोन तो वो 60 mg आपने देनी है 12 गोली हम जिसको देंगे तो पहले तो वो एक बार वो
so
with meal then
अक्सर लोग भी डिवाइडेड डोजेस देते हैं इन कंडीशन ऑफ
so बिल्कुल आप सही कह रहे हैं बाहर तो मेरा नहीं ख्याल है मैंने कभी भी डिवाइडेड डोजेस दी थी we always give only once a day morning dose उसकी वजह क्या कि सिंपल जो इसकी वजह से जो टिपिकल जैसे हम I won't say the psychiatric symptoms people used to get especially at this age bracket elderly patients when you give them steroids a lot of times they would get some symptoms either they would go off sleep so that's why it's always important to give it just in the morning time rather than the late in the evening in the elderly patient but you're absolutely right patients here are always concerned about the number of pills if you give them after every 4 hours they'll be happily no problems but if you give them 6-7 to be taking at the same time but ideally once a day but again it all depends with meals yes with
एक
meals
कुछ अर्सा पहले एक रिपोर्ट आई थी कि गैस्ट्रिक इरिटेशन उतनी ज्यादा नहीं है जितनी कही जाती है.
I absolutely agree with this I
There
don't
was some article.
I personally believe the same that it's very much hyped about this complication of the gastritis and so on so but again of course these are elderly patients we should be prescribing some PPIs with
डायबिटिक से बहुत मसला होगा ना उनका तो
so that's why we have the biologic
डायबिटिक्स तो बहुत खतरनाक
steroid sparing excellent Zabardast.
So biologics.
कॉस्ट क्या है इसकी बायोलॉजिक
This is about 17,000 one injection, which is every 2 weeks. But that's the standard. That's the standard. But the beauty of working in Pakistan is we can play around. So if you ask me in my rheumatology practice, for example, there is only probably I'm talking about rheumatoid as well. I'm talking about all the biologics in my rheumatology. They are very expensive, of course. Not everybody can afford the full.
रूमेटॉइड आर्थराइटिस आप कौन सा देते हैं?
In rheumatology, in rheumatoid arthritis, we've got almost 10 different options.
नहीं जो आप देते हैं जो सस्ता तरीन हो
जो सस्ता तरीन हो वही तो मैं बताने लगा सस्ता तरीन that you can come up with a plan. जो मैं अपने फेलोज को कहता हूँ rheumatology is an art, it's not a science. देखो मैथ नहीं है.
मेथोट्रेक्सेट का जो यूज है ये साइटोटॉक्सिक ड्रग के तौर पे तो ये भी सबसे इफेक्टिव है.
हाँ जी वो जो मैंने आपको स्लाइड्स दिखाई थी Methotrexate has not shown of much benefit. There was one study initially which was shown some modest benefit but not much.
Rheumatoid arthritis में methotrexate भी कर.
हाँ जी उस rheumatoid में is a wonder drug. But what I was telling about the biologic, so जो मैं कह रहा था ना कि it's an art, it's not a science. वो ये होता है कि आप you talk to the patient. वो जितना मैं तो उनसे अक्सर से ही पूछता हूँ कि जो बैठा होता है पेशेंट कि मुझे बताओ तुम अफोर्ड कितना कर सकते हो उसके मुताबिक से आप एक डिवाइस करें जैसे एक मैं कहता हूँ ना कॉकटेल आप बनाते हैं उसके कि जिसमें आपने एक बैलेंस रखना है जिससे हम बड़े पेशेंट से अब रूमेटॉइड आर्थराइटिस है ये कौन सा कोई 1 साल की डिजीज है.
मेरा क्वेश्चन वही रह गया आप कौन सा देते हैं जो सस्ता तरीन
मैं वही कहने लगा सस्ता सारे दे कम अराउंड द सेम ब्रैकेट ऑफ 30
के दे रहे हैं
नहीं वही मैं कहने लगा मुझे 30 to 40,000 की पर मंथ इनकी है जो अगर आपने 30 to 40,000 अप्रोक्सीमेटली जो इनकी ऑलमोस्ट जो स्टैंडर्ड डोज एंड यू आर टॉकिंग अबाउट ऑफ कोर्स ईयर्स लॉन्ग डिजीज तो फिर आप क्या करते हैं कि पेशेंट से पूछते हैं कि कितना व्हाट दे कैन अफोर्ड सो मोस्ट ऑफ माई पेशेंट्स आर ऑन हाफ डोज तो मैं उनसे कहता हूँ ठीक है फिर बाकियों से हेल्प लें आप 1-2 और डीमार्ट्स ऐड करते हैं या जिस तरह फॉर एग्जांपल इसी की बात करें चलें जी GCA फॉर एग्जांपल है आप रादर देन कि आप फुल डोज बायोलॉजिक दे के उसको स्टेरॉइड से ऑफ करें उससे कहें चलें जी 1-8 डोज थोड़ी बहुत चलती भी रहेगी स्टेरॉइड की 1 टैबलेट आप अब मुझे ये बताएं आप अफोर्ड कितना कर सकते हैं. अगर वो कहता है मैं 1 ही इंजेक्शन अफोर्ड कर सकता हूँ महीने का 17,000 का है चलो कोई ना कुछ हेल्प तो लेना फिर आप वही मैं कह रहा हूँ कि बैलेंस करते हैं तो ये इसलिए रूमेटोलॉजी बड़ी मज़ेदार है सेंस में कि ज़ाहिर है वी हैव टू गेट द हेल्प मेरे लिए तो बड़ा इजी, आप प्रिस्क्रिप्शन लेके मरीज को पकड़ा दें, पसंद आता है तो ले लो, वरना कहीं और जाओ। वो फिर यही जो पाकिस्तान में डॉक्टर शॉपिंग की हो रही है, यही हो रही है ना।
You have to make sure that he takes the medicine and gets better.
बाहर तो डॉक्टर शॉपिंग होती नहीं है, उसकी वजह भी खैर और भी बड़ी है, लेकिन जाहिर यहाँ ये भी होता है कि पेशेंट ट्रस्ट ही नहीं है, ना ही डॉक्टर ट्रस्ट करता है पेशेंट में, ना ही पेशेंट को होता है कि
ये
तो आप आराम से हर बंदा।
एक तो टोसिलिजुमैब आपने बताया, और कौन सा यूज होता है?
इसके लिए सिर्फ एक ही है बंदा,
अच्छा
नो वन एल्स।
अच्छा,
तो इसके लिए अभी तक लाइसेंस भी एक ही है, प्रॉपर स्टडीज भी इसी पे हुई हैं जिसके सबसे अच्छे रिजल्ट आए हैं, और हाँ जी और पाइपलाइन में है, लेकिन अभी तक इनका जो रिजल्ट सबसे अच्छे सीखे और लाइसेंस भी है। तो इसलिए दोबारा मैं कह रहा हूँ कि जो हम बहुत ज़्यादा वरीड होते हैं ना कि जी ये बड़ी महंगी ड्रग्स हैं, महंगी तो हैं लेकिन हम वी कैन स्टिल कम अप विद सम। वही मैं जो कहता होता हूँ, जैसे हम अब बहुत ज़्यादा हम लोग यूज़ करते हैं, एक कहते हैं ट्रीट टू टारगेट। ट्रीट टू टारगेट क्या होता है कि एक टारगेट आपने अचीव करना है, टॉकिंग टू द पेशेंट। अब पेशेंट कहता है कि मेरे लिए टारगेट ये है कि मेरे इतना का गुजारा हो जाए कि मैं अपने जोगा हो जाऊँ, मेरे लिए काफ़ी है। तो आप अब वो इंटरनेशनली गाइडलाइंस को ना फॉलो करें, फॉरगेट दोस थिंग्स। मैं तो अपने फेलो से ये कहता हूँ इंटरनेशनल गाइडलाइंस दायरे है वो बेस्ट सेंटर्स के लिए बनी। आपने ये बताना है कि इसमें में जो कोई बंदा बैठा है या चीजावतनी में मरीज बैठा हुआ है गाँव में, उसको कैसे ठीक करना,
उसका क्या टारगेट है, बिल्कुल सही।
तो रात दिन कि आप लंबी चौड़ी उसको एक पकड़ा दें कि ये चीज़ें करवाओ, उसके बाद वो आपके पास आएगा ही नहीं, वो 1000 टाइम्स मच वर्स ऑफ रादर देन कि आप उसको एक बेशक लो लेवल की ट्रीटमेंट करें लेकिन उसको कुछ ना कुछ हेल्प तो करें ना। तो इसलिए इसको कहते हैं ट्रीट टू टारगेट। लेकिन वो टारगेट आपका नहीं होगा अकेले, वो टारगेट मरीज का भी होगा। तो इसलिए
बेसिकली यू आर गोइंग टू ट्रीट द पेशेंट,
बिल्कुल, तो इसलिए
भी आपने पेशेंट सेंटर्ड होना चाहिए।
इसलिए इसको ट्रीट टू टारगेट में जो टारगेट होता है वो म्यूचुअल होता है। मेरा तो यही होगा आइडियल की चीज़ जबरदस्त मरीज फिट हो जाए, 100% हो जाए, लेकिन ये भी है कि मरीज क्या चाहता है।
सिम्प्टोमेटिक इंप्रूवमेंट के अलावा जो स्ट्रक्चरल डैमेज हो रहा है, जैसे रूमेटॉइड आर्थराइटिस में जो डैमेज हो गया सो हो गया, तो अगर आप उसको उस लेवल तक ट्रीट नहीं करें कि डैमेज को रोकना है
जी
और सिम्टम्स को भी रोकना है, तो जाहिर है वी हैव टू गो टू द गाइडलाइन देन।
बिल्कुल गाइड
कहते हैं जीरो डैमेज हो,
बिल्कुल
और रेजिडुअल डैमेज ना हो,
बिल्कुल एब्सोल्युटली जी। वो तो मैं कह रहा हूँ हमारे लिए तो मेरे लिए तो ज़ाहिर गोल्ड स्टैंडर्ड यही है कि जी किसी किस्म की भी मरीज 100% फिट हो, और वो भी आज का फिट ना हो, वो तो भी मैं किसी और दिन करूँगा। वो कोमॉर्बिडिटीज जिस तरह अब हम रूमेटोलॉजी में वी आर नॉट टॉकिंग मच अबाउट द डिजीज़ तो हम कहते हैं कंट्रोल हो गई हैं। अब उसकी आगे की फ्यूचर का देखें, कोमॉर्बिडिटीज जिस तरह अब मैं आई विश कि मेरे पास मेरा अपना लैपटॉप होता है, उसमें दिखाता है कि वो मेटाबॉलिक सिंड्रोम पे हम बात कर रहे हैं। वो नेक्स्ट वीक मेरी एक और प्रेजेंटेशन उस पर हमने वो कुछ रिसर्च की थी उस पर कि पेशेंट आता है फिट होता है। अब जिस तरह एक पेशेंट था हमारा जिसके बाद हमने इस पर फर्दर काफ़ी उस पर किया काम, एक पेशेंट था हमारा बड़ा फिट बिल्कुल। अब वो जब हमने उसको यही मेटाबॉलिक सिंड्रोम, जब कार्डियोवास्कुलर रिस्क्स को, ये आज से 7-8 साल पुरानी बात, उस पर देन वी स्टार्टेड लुकिंग एट जी कार्डियोवास्कुलर स्क्रीनिंग होनी चाहिए। अब जहाँ भी आप जिस जगह भी देखेंगे वो ये कहते हैं कि जो जितनी इन्फ्लेमेशन डिजीज़ होती है, ये स्ट्रक्चर डैमेज हो गया, वक्ती तौर पे पेन होगी, ये तो हो ही रही है। जो बाकी उसकी अदर कॉम्प्लिकेशंस हो रही हैं बिकॉज इन्फ्लेमेशन की वजह से कार्डियोवास्कुलर रिस्क, एथेरोस्क्लेरोसिस होती है। अब हम कहते हैं ना एथेरोस्क्लेरोसिस है, ये ज़्यादा हो गया, ये तो खैर वैसे कोलेस्ट्रॉल की वजह से। अब कोलेस्ट्रॉल का से ज़्यादा इन्फ्लेमेशन का भी रिस्क है। ये जो डिजीज़ है हमारी या कोई भी हैं, ये ओबेसिटी जिस तरह आपका ये सारा का सारा दीज आर लो लेवल ऑफ इन्फ्लेमेशन जिसकी वजह से होती हैं सारी। तो इसलिए जो मैं कहना चाह रहा था कि ये जो स्ट्रक्चर डैमेज है, ये वो डैमेज अब ये भी है, इससे भी आगे की सोचते। ये तो है हमारे स्टैंडर्ड्स, ट्रीटिंग फिजिशियन स्टैंडर्ड्स, कि हम तो सारे चाहते हैं मरीज के सबसे बेस्ट आउटकम्स हो, लेकिन एट द सेम टाइम हमें मरीज से भी पूछना कि मरीज तो आपको पता है यहाँ उनको डिजीज से ज़्यादा ड्रग्स की एंजाइटी होती है। पाकिस्तान में ये पता नहीं क्या है, वो डिजीज़ का उनको कोई वो जी बस दवाइयाँ छुड़वा दो जहाँ।
थैंक यू।